Hello, good evening, everyone. Welcome to the European Fertility Society and my IVF Answers. We are back once again with Dr. Elias Tsakos. I'm sure you can see him right here. Hello, Dr. Tsakos. It's lovely to have you back. This is your first event this year, but of course we go way back when it comes to the events. I'm really happy to have you back. As we already established at the beginning, you are full of energy today and you are ready to educate us on implantation failure. How have you been? And welcome to my IVF Answers once again.
Hello, Caroline. Hello, everyone. I'm really happy to be here. And this is a very hot subject, very hot topic. And we already see a lot of questions on the chat box. So I'm looking forward to trying to convey some of my experience and, if possible, all of it, and hopefully help some of you achieve your dream to parenthood.
Definitely. Thank you so much indeed. Just before we start with the presentation on our topic, we will please remember that you can still type the questions in the chat right now. Later on, Dr. Tsakos will definitely take care of them for you. We have about 1 hour for the whole event. We already received lots of questions in advance from you, so thanks a lot for that. And of course, keep going and keep sending them, and we are simply here to help you out. This is being recorded as well. And you can also watch us right now on YouTube, but also on Instagram and Facebook. So thanks everyone for joining. Let's go ahead with the presentation. I'm sure we are all eager to listen and learn, right? So let's go ahead.
Of course. Thank you, Caroline. I will try to be a bit provocative today. I mean, I will give you the short talk. It's only 15 slides. I kept it very simple on purpose. I took away all the decoration, all the titles, all the photos, because I like to be very simple and straight with you today and try to give you perhaps some information that you haven't heard before. So I will start in an opposite way, if you don't mind, Caroline. I will, because I have some wonderful questions on the chat box, and I will try and set the rhythm, the pace. So if I can take the first question from Danielle. So no presentation first. I will take those 3 questions, which I think are amazing. And then I will go through the presentation. And then
definitely,
if that's okay with you, we'll take some more questions.
We can definitely go ahead with the questions that we've got here.
Sure.
So do you want to start from the beginning?
Biochemical pregnancy and a miscarriage, all with euploid embryos. I have been diagnosed with stage 3 endometriosis by one physician. Another told me without biopsy they can't confirm. I have 8 centimeter endometrioma on my left ovary, all a current pregnancy failure, I suppose. Testing has come back normal. One physician suggested thalassemia testing. I mean, Danielle, this is half of fertility. I mean, I don't know how you managed to get such a concise message. Thank you very much. So I'll take it one by one. And this can be a model actually for my presentation later on. So Danielle has had 2 failed implantations, all with euploid embryos. This is very important piece of information, Danielle. Euploid embryo failure is the new definition of implantation failure. In the past, even until now, some of our colleagues and some of our patients, they define implantation failure, the failure of 3 embryo transfers or 4 good quality embryos. And we know that this is not very valid because, for example, a 44-year-old may have 5 or 6 implantation failures, all related to abnormal euploidy of the embryos. So to make it very clear, we define the new definition, which is very logical. One of the few cases where as doctors we retain a bit of logic. So implantation failure by definition is when a good embryo, a euploid, a DNA normal embryo fails to implant. And although there's no strict definition for that, is it 2 or is it 3? We're somewhere there. So Danielle, between 2 and 3 in my opinion. So you are by definition one of those cases. And I'm sure you've done your homework, and thank you so much. I think it's very important to come through. Euploid embryos. So if I want to take it a step further, you've had a couple of failed implantations, insist on having PGTA testing before the next embryo transfer, because it's very important to either ensure or exclude DNA abnormal embryos. So at least by doing PGTA, we have ensured that the embryo, in terms of DNA integrity, is normal. And therefore, we're then looking into other factors of implantation failure. Now, the second very important factor, again, that you bring up is endometriosis. I'm sorry about this diagnosis that you have it. You're one of perhaps, in my practice, 50% of my IVF patients have, of my fertility patients, have endometriosis. It's as high as that. 1 in 10 overall. So 1 in 10 of 20, 30, 40-year-olds working around, if you like, with or without fertility, but perhaps 1 in 2 with endometriosis. Now, someone said, very wisely, that they cannot confirm without a biopsy. I agree with that person, because if you have an 8 centimeter endometrioma, this is probably labeled endometrioma based on the scan findings. The chance is that it's probably endometrioma, but not definitely, because a cyst that has bled, a follicular cyst that has bled, a cystus cystadenoma that has bled, may resemble on the scan with endometrioma. And the only way to diagnose that is with a biopsy. So I would fully agree with that person. As I said, I mean, Danielle, your question, your history of 5 lines could initiate a whole conference. This is how important it is, and this is how challenging it must be for you and for us also. I mean, you carry on you all this pathology, but I would like to be very optimistic. I would like to stress that. So in my opinion, 8 centimeters is a big cyst. It's a most likely endometrioma cyst. I would have it out. And before you move on to surgery, I will justify why. For many reasons, not just for fertility, for your health reasons. Even if you've had your children, if you had completed your family, an 8 centimeter cyst or hemorrhagic cyst is a potential risk to your health, either through rupture, through twisting and strangulation, and even through its own diagnosis, because the chance of a benign cyst is probably 99%, perhaps 99.5 or even 9.9, but it's not 100% benign. So please have it out. And of course, before you have it out, make sure that you have all the workup associated with the potential presence of additional endometriosis, if it is endometriosis, in the pelvis. And you can achieve that through high resolution imaging. In my opinion, 3D scan in expert hands may be perhaps better than MRI scan in not so expert hands. I usually suggest both, because these are complementary tests, but indeed your physician, your gynecologist, your endometriosis specialist would need to take very extra care to read those images and perhaps discover or exclude the presence of other spots of endometriosis anywhere else. Of course, they would need to evaluate your symptoms, etc., before moving on. ALICE and ERA testing have been phased out. There is very strong evidence now suggesting that they're not helpful. To my knowledge, even the inventors of those tests now have moved away from that. So perhaps I wouldn't suggest that. In my practice, I never practiced it because I was never convinced by the then existing evidence, and recently the evidence now is probably against it. Yeah, that's what I would do if you were my patient. And then you're 35 years old. Your chance of having more euploid embryos is very, very high. Get rid of the cyst, get rid of endometriosis if you have it, get rid of inflammation. I would definitely keep on producing embryos, keep on testing. Once you have ensured 2 or 3 top quality euploid blastocysts, freeze them and then work on the endometrium. If I were to choose between a fresh and frozen cycle, especially in cases like you, I would definitely go for a frozen embryo transfer, perhaps in a natural cycle, having optimized not only your uterine environment, but also your surroundings. I would get rid of the inflammation. I would ensure that even if there is or there was endometriosis or adenomyosis, I would keep it at bay as much as I could medically in order to reduce the inflammation. I would work very hard on the endometrial implantation capacity by doing a hysteroscopy, perhaps 3D ultrasound scan, taking samples for microbiome testing and endometritis testing, and then paying huge attention into the absolute fine details of embryo transfer. So I think that's all my lecture. Danielle, I can love you and leave
Thanks
you
a
now.
lot. Thanks a lot. Lots of details indeed, thorough answers. So thanks a lot for that. Danielle, if there's anything else, you know what to do. Dr. Tsakos, let's have a look at the next question here.
Yeah, if you don't mind, let's do the presentation and then we can
Not
come
a
back.
problem at all. We can do
Thank you.
that right now, of course. Let's go ahead with the presentation then.
Thank you. So, yeah, only 15 slides, nice and simple. So what's the definition? It used to be failure of implantation after 3 embryo transfers or more. Now we're moving towards good quality DNA tested, DNA normal embryos. So as I said before, I'm very skeptical if we define implantation failure a case of a 44-year-old who's had untested embryo transfers that failed to implant, because in that case we know only too well that the chance is that those embryos were not competent DNA-wise. So after a couple of euploid blastocysts that failed to implant, this is probably the definition of implantation failure. Why is it important? Because, of course, this is the start of a pregnancy, and if it doesn't start, it doesn't finish, and it is very important to define that. Of course, there's an additional definition, which is the primary or secondary, which is associated to whether someone has achieved a pregnancy before or not. And there's an overlap between, in the etiology, between implantation failure and recurrent miscarriages. To my mind, there's very clear, although there are some common reasons why this may be happening, there's a very clear discriminatory factor, which is the fact that recurrent miscarriage is usually associated with spontaneous pregnancy, whereas implantation failure is associated with assisted IVF embryo transfer. It goes without saying that the burden is massive, and that's why for us it's very important to try and understand why it's happening. And although that the definitions were based on cycles, how many embryo transfers, now we focus on the embryo competence, simply because the embryo competence is one of the most important and decisive factors for successful implantation. And of course, implantation happens and occurs when this dialogue is happening in a positive way, and when the timing of the embryo transfer and the receptivity of the endometrium are optimal. So it may be embryo related, it may be endometrial related, it can be systemic. We can mention a few factors affecting there. More often than not, it's multifactorial. And I would like to be a bit provocative and say that there's also factors that are not mentioned in the textbooks or in the journals, scientific journals, such as the exact timing. Is it morning? Is it lunchtime? Is it afternoon? How many completed days of progesterone have we given? At what dose? In what mode of delivery of the drug? There must be some impact. It hasn't really been proven yet, but we have to be aware of that. Is it oral? Is it vaginal? Is it subcutaneous progesterone? Is it intramuscular? Is it a combination of all of that? Have we ensured compliance? We know that measuring progesterone is not that very accurate, especially in the blood, since the variability can be very big, very much dose related, very much drug related, and of course it doesn't give us very much of information. And now there's a trend towards measuring urine progesterone and all that. So there's a lot of fine detail that may affect the actual effect. And of course, the handling of the embryo, who handles the embryo, how do they hand it from the lab to the physician, to the fertility specialist? How is the embryo transfer taking place? Is it ultrasound guided? Is it not? I was very surprised to see that some people still practice non-ultrasound guided embryo transfer. Is it abdominal scanning? Is it vaginal scanning? What kind of catheter we use? Is it the soft catheter? Is it an easy transfer? Is it a difficult transfer? So, embryo transfer by definition is not always optimal. And there is a human factor that is not always optimal. I think we have to accept and admit that. And it may play a role. So there's no real point looking into the coolest gadgets, into identifying the best possible embryo, culturing in the best possible incubators, using time-lapse, AI, and so forth. If at the end of the day, there is some clumsy moment in which the embryo is not placed in the quite best place or under the best possible guidance. That's why, in my opinion, it's very important, especially even after one failed embryo transfer of a very good quality embryo, to readdress the whole scenario, the whole scene, if you like, of embryo transfer. Who is the most senior embryologist handling the embryo around, and who is the most senior fertility specialist doing the embryo transfer? So in the era of industrial level IVF units, these are factors that perhaps may not be 100% optimized. So returning to the scope of my presentation, aneuploidy is the main cause. Aneuploidy. So if there's any doubt about implantation failure reasons, look into the embryo first. And of course, the role of the PGT-A testing remains important, although there is some evidence that it's challenging a little bit that belief. But until now, the main core of evidence favors the use of PGT-A under specific circumstances, especially women over the age of 35, women with failed implantations, with untested embryos, and so forth. Receptivity window, very important. And this is what the ERA test or the Alice test tried to solve, unfortunately unsuccessfully. So there's a number of ways we can calculate that, whether it's a fresh cycle or a frozen cycle. In a fresh cycle, we need to be very wary of the conditions. I don't have an absolute opinion here. And actually today, thank you. Good night, Anna. It's 9:25 in Greece now, and we're just now shutting off the unit for tonight. Back tomorrow at 7. So I'm now left alone, which is fine. So the receptivity window. How do we do that? How do we monitor? It's only recently that progesterone acquired an important role in defining this window, especially in first cycles. fresh or frozen. I recently heard a very well-known colleague of mine who was quite adamant that frozen is best. I'm not sure. I mean, in my opinion, the clear answer to whether fresh or frozen is best is depends. If the conditions are optimal for a fresh transfer, I would probably prefer it. I mean, it goes without saying that invariably if we do that, we don't have the time to do proper PGTA testing and so forth. So these are factors that have to be taken into account. And of course, our couples, our women, our single women and our couples, they need to be part of this discussion and equation. And always there's the logistics because, some couples travel from the other side of the world. We cannot ask them to come back because we think that perhaps a frozen cycle is better than a fresh and so forth. So there's a lot of factors that have to be taken into account. IVF now has become a very, very challenging and complex procedure. Our couples, they travel all over the world in challenging times, looking for this better solution, if you like, and better outcomes. So, we have to listen to them as well. We have to listen to their particular needs and requests. So my algorithm is very simple: embryo, uterus, and systemic. I avoid over-testing. I'm very careful in evaluating the tests. We're under a lot of pressure from the couples, from patients to do anything that there is out there, doctor, but sometimes this is not for their benefit. So we have to be very clear about that, what's evidence-based and what's not. The importance of evaluating the uterus, I'm still surprised to see many IVF units not using 3D scanning in expert hands. I think that we're missing out a lot there. It's not just the thickness of the endometrium, there's a lot more factors there associated with normal functional endometrium, and then it's the myometrium also, and then it's the adnexia also, which are important, and then it's the possible endometriosis in the pelvis that we can pick up with a high quality 3D scan. In my department, we have invested heavily on 3D scanning. We offer everyone going through IVF, IUI, or fertility investigation a very high top-level 3D ultrasound scan, trying to unravel, if you like, any hidden pathologies that may be relevant not only to the success of IVF, but also to the implantation, to the reduction of miscarriage rates, and so forth. And we're just now setting up a prospective study trying to look into the comparisons of other parameters on the 3D scan versus the conventional scanning that just looked into the endometrial thickness and perhaps together with the shape, the laminar shape and all that. And I'm very confident that we will probably identify some subgroups of patients that will benefit from that intervention even before the first embryo transfer, because anything we can do to avoid implantation failure well before it becomes recurrent would be for the benefit of our patients. I mentioned my opinion on ER test. Very important, personalization. And, if a protocol fails, I like to challenge myself, my team, and of course our patients, and try to change that and turn a failure into a success by looking into other options. Now, systemic factors, hormones, very important. Equally important in fresh stimulated cycles and frozen embryo transfers. Pathology, very important. Is the endometrium normal? One of the IVF cases I will never forget was a lady with a complete uterine diaphragm that was going straight into the vagina, dividing the vagina into two parts, who's had so many failed embryo transfers before she even had a diagnosis. A wonderful English lady who we treated successfully more than 12 years ago, and simply that diaphragm was completely missed. So it is very important to identify pathology and treat it. Anything that's within the endometrium, I'm bothered about. I don't like it. I don't like what I see in the endometrium, and the more I scan, the more I see. The chance of an endometrial polyp or a small myoma touching the endometrium or being on the endometrium, the chance of infection of the endometrium, imbalance of the microbiome of the endometrium is pretty high. So I'm very careful. I mean, I like, once I'm done with the embryos and I'm happy with the quality, I'm really focusing on the endometrium. Sometimes we need to do this in two steps. I mean, today I had a wonderful patient with lots of pathology from Serbia. That patient was lots of pathology outside the uterus, ovarian cysts, potential hydrosalpinx, maybe endometriosis, adenomyosis on the uterus, adhesions, and a possible polyp. I said to them, forget that. Let's focus on the eggs. Let's get the eggs. Let's make embryos. Let's test them. Let's secure that we have at least one or two euploid DNA tested to good quality blastocysts. And then we put them to the side, and then we focus on the endometrium and the surrounding areas. So I'm happy that the definition of implantation failure has now divided the patients into two groups, the ones with euploid embryos and the rest, because this is helping us, clinicians, to stratify our focus. And the first focus, in my opinion, should always be the embryo, because this is time sensitive. It may take us a few months, 6 months, 8 months, 1 year to get to one or two top quality blastocysts, and then we just move on to the rest. Also, it's another amazing example I had today. Another wonderful patient who received an email today, who had recurrent implantation failures, came to us. There was something odd on the scan. We convinced that lady, who lived in London at the time, although she came from the Balkans, to have a laparoscopy, and we found a very rare condition, inflammation condition, on laparoscopy. It was so rare that we published that a few years ago. She was treated successfully, rare condition with 100% cure with the appropriate treatment. And today she sent us, she went on, moved countries, had IVF in another unit, and sent us the wonderful babies that she delivered today through the mail. So don't forget the environment. The seed is important. The soil is important, the endometrium. The environment is important, the uterus and the peritoneum. And the climate is important, which is the systemic factors. So more or less like our friendly farmers. Okay, what can we do to improve implantation? A lot of things. I mean, I just mentioned PRP. There is some evidence recently. I mean, PRP has been used for more than a decade now with scanty evidence. Evidence is not very solid, but it's there. It's been there now with two wonderful meta-analyses in the last couple of years. And it may be indicated in some cases, not in all cases, in my opinion, in cases where everything else has been excluded and corrected and optimized, and in cases where there's been uterine surgery that has created either adhesions in the endometrium or thin endometrium, which is unable to grow despite treatment. So, I'm very cautious, but I do use PRP occasionally in the endometrium, either via flashing or via injection, with good outcomes. However, it's not one size fits all, and it needs individualization. Now, growth factors, sildenafil, also, we may use selectively in some cases, but in my opinion, the majority we can exclude by doing simple measures like simple hormonal tests, exclude any serious immunological disease, exclude any serious hormonal imbalance, improve anatomy, exclude endometriosis adhesions, endometritis, and of course focus on the embryo. Future directions include AI embryo selection and of course genomics and microbiome. I think we're getting there. There is emerging evidence. Most of the units, including ours, we use AI tools in order to select the best embryo, together, of course, with the experienced embryologist, together with, of course, any technology we can use in the lab. But no matter what we do, unless we actually check for the DNA, we can never be sure. Our team has published a very interesting collaborative work a couple of years ago, together with a number of units from Europe, mainly from Italy, on non-invasive DNA integrity tests of the embryo based on blastocyst microRNA checking. Perhaps that is the way forward. That may be the way forward, which is less invasive than PGT-A testing. Perhaps in a similar way that the non-invasive prenatal testing in pregnancy has acquired a very important place in diagnosing antenatally abnormalities. So there's a lot of research being done at the moment, and hopefully we will have some very good evidence to offer to our patients very soon. So the last slide is we like to invest on quality over quantity. So, perhaps 5 good quality embryos, especially in women over the age of 35, may probably represent a maximum 2 or 3 euploid embryos. And precision medicine is key for every single patient we treat today, especially those patients who have experienced implantation failure. In my opinion and in my team, we tend to support them in every possible way, and one of them is to get the most senior people in our team perform even the physical acts of embryo handling and embryo transfer under the best and the most optimal possible conditions. Thank you very much.
Brilliant. Thank you so much indeed for the presentation. And of course, now we will go for your questions. We will continue answering your questions. And there were some questions that you have added. So let's get to them. Plenty of those. I will start from the beginning to make it easier for us.
1 second.
Sure, not a problem. And in the meantime, let me remind everyone that if you have any questions, you can put them here. We did receive some questions also on Instagram, so keep them coming. We have about 30 minutes to answer them. And remember, it's also being recorded, as someone already asked us on Instagram. So don't worry, it's being recorded. It will be available on our website, My IVF Answers, tomorrow. And it will be available on our YouTube channel right away, so right after we finish. If you need to get going, I know that sometimes you don't have enough time to spend all hour here, but you will be able to watch the recording right after we finish. So let's get to the questions. The question that I have here, the first one that we got: do you recommend further testing after first implantation failure of PGT-A tested embryo if only one embryo is left?
Sorry, I can't see that.
Can you scroll up? You should be able to see the first one, but just so I can repeat that. So do you recommend further testing after first implantation failure of PGT-A tested embryo if there's only one embryo that's left?
Okay. Look, I'm not sure. Is that embryo tested? It's euploid, yeah?
Yes, PGT-A tested embryo. It's only one that is left, yeah.
Okay. I want to be clear here. I would do everything. Absolutely. I mean, how old are you? Sorry, do we know?
There's no information, so we don't know, but if you can...
One euploid embryo, the value of that embryo is huge. I mean, if you're in your, for example, late 30s, the value of this embryo is equal to 2 embryos untested at the age of 35. If you're 40 plus, again, the value is, so this is a very precious embryo. So I would definitely focus on the endometrium. I would do a 3D scan, high resolution 3D scan, to ensure that the myometrium and the pelvis is normal. I would do a hysteroscopy, definitely hysteroscopy, office hysteroscopy, not a big deal. Have a look around, take a little bit of a biopsy. Scratching has been very much in vogue now, not so much, but in my opinion, it doesn't harm. So take a little bit of biopsies and test for at least standard biopsy, endometritis testing, and maybe microbiome testing. It doesn't harm, because there is evidence that if you correct that, you will have better outcome. Definitely that. And then go for the frozen embryo transfer. If you're having a normal cycle, of course, natural is best. I mean, natural fat frozen embryo transfer in a natural cycle, provided the cycles are normal and predictable, is giving us better outcomes for both pregnancy and the mother. Timing is very important. In a natural cycle, yeah, we may or may not. I mean, I usually give a little bit of orbital injection. I want beta-HCG. I like that because this is promoting the corpus luteum, sustains the corpus luteum, which is producing the natural progesterone. And I always supplement a little bit of extra progesterone. Again, in my opinion and in my experience, which is now coming up to about 35, 36 years, a little bit of more extra progesterone doesn't harm, whereas a little bit of lower progesterone perhaps does, especially in the early stages of pregnancy. So natural cycle, beta-HCG trigger, supplement a little bit of progesterone, perhaps a little bit of estrogen. It will not harm. There is a subgroup of patients that may benefit from that, in my opinion, as compared to the absolute natural cycle. And then have the embryo transfer, request your team. I don't think any team would refuse to have to provide you with the most experienced people around to do the embryo transfer and the embryo handling. And then, of course, the support of the pregnancy, the appropriate support, mainly with estrogen and progesterone.
Yeah, thank you. I think that was useful for you. And you mentioned this during your talk right now about supplements, because there's a question about this. Do supplements and lifestyle have an effect on implantation?
When I said supplement, I meant estrogen and progesterone. I didn't mean anything else. But in terms of other supplements, like vitamins and so forth, that's a huge discussion. Hello, England. Hi, David. Huge discussion about that. I like to individualize. There's a massive trend, as I'm sure you know, towards supplements. That's an endless discussion. I like to individualize. I believe there are some essential supplements that most people are missing, especially in the North Europe, like vitamin D. But again, depends on the level. I would definitely, I check for vitamin D levels. And even in Greece, with the sunshine, most of people are deficient simply because they don't expose themselves to the sun. So, however, I'm cautious. Folic acid, of course, I would supplement. Again, it's not as simple as it sounds. Some people know, some people don't, that unfortunately folic acid is not actively metabolized efficiently in as many as 40% of patients, myself included. So if I were to blindly supplement with folic acid, I would choose the active form, which is the folate acid. If I were to be a little bit more scientific, I would probably check for mutations, anti-HFI mutations, and homocysteine in order to individualize. So there's a lot of little tricks of the trade there that I would definitely focus on. I focus on even before the first embryo transfer. And that is mainly because most of my patients, they've had so many failures in their countries before they come to us, or in Greece for that matter. We hardly ever, I mean, when we see a virgin couple coming for the first IVF, we have a celebration. It doesn't happen very often. So even before first embryo transfer at Embryoclinic, I treat them in a way like implantation failures with simple measures, not going over the top, if you like.
Okay. Brilliant, thank you. Just to check it with you, can you see the previous questions or just the ones that are at the bottom, just to make sure? Because there's a long question and I just want you to see it, to be honest. It's from Anna.
From America. So Anna.
It's at the top, almost at the top, Anna. Age 40, PCOS.
Yeah, I can see it, yeah.
Perfect. So PCOS diagnosed with ultrasound, endometriosis diagnosed only clinically, positive lupus anticoagulant, AMH 52 picomoles at age 36, BMI 19, to egg collection 71 mature eggs for 11 blastocysts on day 6, PGTA 4 euploid embryos, hoping for 2 children from this, not much room for error, no natural pregnancies from 2 years of trying naturally. What testing would you do before embryo transfer, and what transfer protocol would you recommend for best chance of success?
Sure. Wow, Anna. Yeah. Great. I mean, that's another conference topic, yeah, for a weekend.
Yeah, for sure.
First of all, congratulations. You have 4 euploid embryos. The chance of taking home 1 baby, in my opinion, is more than 90%, 95%. So go for it. The chance of taking home 2 babies is also very high. So absolutely. I mean, I would just analyze one by one. I mean, PCOS, have the full investigation to check the metabolic effect, to check the inflammation effect, glucose tolerance, the works, everything. It's good that you only have a BMI of 19, but you may still have some sort of metabolic disturbance. So look into that and optimize everything. Optimize your PCOS. First diagnose and then optimize. Now, lupus anticoagulant, okay, we keep that on side. It's not a huge factor, but definitely optimize it and discuss with your fertility specialist how they would treat it, how they would manage it. Is it aspirin? Is it low molecular heparin? Is it both? If you're not satisfied with your fertility doctor, have a chat with a hematologist who is a little bit sensitive and perhaps experienced in treating fertility patients and pregnant patients, especially with a view to protect you from any mishaps in pregnancy like antiphospholipid syndrome, etc. Yeah, I think that's that. Definitely have a hysteroscopy. Definitely check your endometrium for endometritis. Simple things. I wouldn't go for NK cells. Initially, I wouldn't. Endometritis, CD138, standard biopsy, and microbiome, in my opinion, is more than enough. Now, clinical endometriosis, huge discussion, not very accurate. Depends on the algorithms we all use. Endometriosis is a funny disease. It tends to fool us very, very often, no matter what we do. So definitely have a high resolution scan, perhaps an MRI scan. I wouldn't go beyond that. If you're in England, there is a non-invasive technique, which the data is amazing. It's a little bit of a belt that you put around your belly. As far as I know, there's only a chap in Wales who has it. If you want, I can give you information about that. It may be worth using that. The evidence is amazing. It's so amazing that it's unbelievable. I'm in touch with the manufacturers. I haven't used it. I have no experience, but the person using it in Wales is a top level gynecologist. He was my senior when we trained together in the north of England. So perhaps consider that. No more than that before the embryo transfer. I wouldn't do a laparoscopy, for example. I would perhaps leave it for later if you had failed embryo transfer. And that's it. And I'm sure you will succeed. And please don't forget to drop us a line that you did. And you will succeed.
Definitely. Thank you so much indeed. So let's have a look. Larissa has another question. How can I let go of the fear that even a donor egg won't lead to implantation? Thinking of donor eggs after 12 unsuccessful transfers, 4 ICSI, 2 ICSI, and then natural 6 cryopreserved. With endometriosis and adenomyosis and male factor. I am very frightened of more failures.
Yeah. Sure, of course. I mean, that's natural. I mean, I agree with you. I mean, you're frightened and we're petrified. I mean, that's our biggest nightmare when we have very frequently, unfortunately, cases like you who come to us for egg donation as a last resort, perhaps with partners, male partners in their 50s, where we know only too well that this may affect the integrity, the DNA integrity of the embryo. So I think it's natural to be scared, but just take it one by one. I presume you haven't created the embryos yet. So I think that one good way forward is optimize your partner's health if you have a male partner. If you don't, it's a little bit more straightforward because donors they tend to be healthier than the average male partner. So optimize your partner's health, optimize his sperm parameters. Definitely have, together with semen analysis, also have DFI testing, plus or minus oxidative stress testing. Definitely have a general blood test on the husband, on the partner, in terms of hormonal levels, vitamin D, sugar, metabolic syndromes, and so forth. Try to optimize as much as you can. If they're obese, try to address that. There's an article today in Fertility Sterility that male obesity affects implantation and increases miscarriage rates. So do anything you can from the sperm point of view. From the egg donation point of view, have a frank discussion with your clinic. It makes, how can I be diplomatic here? It makes a significant difference if it's fresh or frozen eggs, especially eggs traveling from a long distance. You have to have a frank discussion. I mean, thankfully, the technology is getting better, but it's not the same. So have a chat about that, the origin of the eggs, the travel, the destinations they travel from, the breaks they have, and so forth, the number of eggs, the quality of the eggs, so forth. This is also important. I mean, egg donation is not the solution for all our problems. Perfect egg, perfect lab, perfect clinician and embryologist would not guarantee a perfect embryo, especially if the male factor is there and it is significant. And once you have the embryos created, then focus on the endometrium. Focus on ensuring, I mean, do you have endometriosis or not? You need to know that. You need to know that not just for the success of IVF, but also for the outcome of pregnancy and the course of pregnancy, and also for your health. So it is very important. I mean, may I make a point here that Caroline has been listening to for the last so many years that we've been working together. Unfortunately, in the last 10, 15 years, IVF training is mainly IVF training, and it doesn't include minimal access training, at least to the extent that it used to be. And now with robotic technology in minimal access, it's definitely going to be divided, in my opinion. So we tend to have IVF specialists who are not surgeons, who have no experience in doing a laparoscopy and looking for endometriosis, or if they see it, they don't recognize it, or if they recognize it, they cannot excise it, or if they excise it, they don't go deep enough, or they don't look in the other part and so forth. So I think that as we move on in time, it becomes more and more important for a multidisciplinary team in every IVF unit, in every fertility unit, providing top-level, world-class fertility expertise, surgical expertise, ultrasound expertise, immunology expertise, hematology expertise, perhaps infectious disease expertise, and so forth. So it is not that simple anymore. And the good thing from all of this, all this knowledge, is that, as most of you probably know, in the last perhaps 20 years, the focus of science has been the lab. And even from our point of view, with all due respect to our amazing embryologists, of course the lab is important, but it's not enough on its own. So I think we have to sit together even more, spend even more time together, honestly, confessing first to ourselves that we don't know everything, then to our colleagues, and of course, then to our patients, that we need to dedicate more time and effort to make everything optimal. Sadly, things are not optimal in our everyday practice, and the only push to make it optimal is patients like you who drive us to become better every day and to give more attention to detail.
That makes sense. Thank you so much indeed for that. We have about 10 minutes, until we finish. There are some questions that we still can answer, I'm sure. So Olivia would like to know, what is the best endometrium lining measurement? Is there anything I can do to improve the lining?
Sure. Presumably, Olivia, you don't have a good lining. I will share with you what I've said about 20 minutes ago, that lining and thickness, this is only one parameter. It's like judging a person by the color of their eyes, okay? There's more features on the face. So there's more feature. I mean, yeah, of course. Some people, when they see endometrium, they only see the thickness or the shape. Some other people, they see more. They see the regularity, they see the density, they see the vasculature, they see the uterus, the wall of the uterus, which is very important, and they also see the surrounding. So, in my opinion, the uterine factor is not just the endometrium, and in the endometrium, it's not just the thickness of the lining. You can have a thick endometrium, which is abnormal in consistency, which may be too thick or too dense or too luteinized, as we call it, or out of phase and so forth. So I think it is very important to address that. In my opinion, before any embryo transfer, in the past we used to do mock embryo transfers. We used to run a mock cycle before we do the actual real one, just to make sure that we're doing the right thing. Now we've moved away from that, but I think that everything has to be optimal. And optimal doesn't mean just thickness, doesn't mean just shape. It means everything. There's good evidence now to suggest that. If there's any doubt, do a hysteroscopy, take some biopsies, make sure everything is normal. Here, I will also stress the importance of excluding hydrosalpinx. Very important. Most people don't bother with that. Most people, patients and doctors alike, they think that, if it's not visible in the scan, it doesn't matter. Hydrosalpinx is a damaged tube that contains fluid. Sometimes we see it, sometimes we don't. Depends on whether this fluid is discharged into the cavity, the uterus, or into the abdomen. One of the first things I check is the tubal integrity. My team and I have published some very good papers, very important papers, comparing the various methods of assessing the tubes. We presented that in ESHRE a couple of years ago. It was published in Human Reproduction. Look it up if you Google Tsakos, HIFOSI, HSG, HICOSI, you will see the comparison. I think it's very important Just like the dentist is always taking a scan or an x-ray before they do some work, because they may be working on perfect tooth here, and if the next one is rotten, it's gonna be a waste of time. So I think that we need to revisit the importance of the uterus environment, which is not just normally thick endometrium.
Okay, thank you for yet another great advice here. Sarah would like to know, how can you best support implantation if you have had a number of chemical pregnancies? This is the only information we have. Anything you can advise?
Sure. Yeah, the first question I always ask is, what embryos did we implant? And and if the embryos are tested or not. So to my mind, everything is very clear. Focus on the embryos. First of all, we need the seed. We're not farmers, human farmers, unless we have seeds. And seeds are embryos made of optimized eggs and optimized sperm. So focus on the egg collection. Before the egg collection, make sure we're dealing with a healthy woman. If not, optimize that woman, stimulate effectively, collect the eggs, prepare the sperm, utilize any technology under the sun that could help the sperm. I mean, more often than not, now we use some sperm sorting techniques in the lab that improve the sperm selection, especially when sperms are associated with high DFI, or in older patients, or sperm with low parameters, and then create top quality embryos. Go to blastocyst level, very important. I mean, I still see embryo transfers happening on day 2, day 3, which is okay perhaps for the first embryo transfer in a young person, but not okay if someone is moving on to becoming recurrent implantation failure. In that case, blastocyst is very important, because that ensures that the embryo integrity, the embryo quality, the embryo potential has reached a very, very important stage. And then do PGT-A testing to make sure the embryos are at least DNA normal. Once this is ensured, then focus on the endometrium, the implantation, and the environment.
Of course, brilliant. Thank you so much. And there are like 2 questions from Erica here. Let's have a look. So, what do you think of NK testing, blood or uterine, lifestyle or stress, has any effect on implantation? And she also asked about any alternative therapies you probably could recommend, like acupuncture, reflexology, stress reduction. Any experience with this?
Yeah, absolutely, Erica. Implantation is a magical moment in human life, in female life, where the dialogue between the embryo and the endometrium reaches a conclusion, and that conclusion is the implantation. So anything we can do to improve this dialogue, to improve the conditions even before this dialogue takes place, is of course very important. Now, NK testing, it wouldn't be my first step. It wouldn't be my first recommendation. Surely I don't do it routinely. There is some evidence. There is some theory there. It's not very solid. It's not proven. The theory is there. The evidence is not solid. I don't discard it, but I don't use it as a first or second or third priority. I use it at the end, both blood and uterine. It may play a small role. It may be improved. Even the placebo role may be important. So that's my opinion on that. Now, of course, lifestyle and stress is important. Of course, it's like before a final match, before an athlete goes to performance. They need to be stress-free. They need to be relaxed. They need to be well-fed. They need to be hydrated, and so forth. So anything you can do. I mean, think of your body as a temple. I mean, it's a temple. It has to be pristine, especially around the time of implantation. And we know very well that even in spontaneous pregnancy, the most important time, moment for the development of the embryo, not only in utero, but also in later life, is before conception. That's why preconception care is very important. So yes, it goes without saying. Now, in terms of complementary treatments, I have to admit I'm a big fan of acupuncture. I was taught that not to perform it, but I was introduced to acupuncture by some amazing people, many of them from England, a wonderful person from Serbia, and some other local people here in Greece. I've tried it myself, and the mechanism, there is evidence for acupuncture in improvement of fertility outcomes. But I mean, the simple mechanism relation is that acupuncture is good for stress reduction, as simple as that. And stress reduction is associated with cortisol reduction, with better metabolic health, with better function. And if you like, even if this is minimal, with better experience. If the experience is better, then even if the outcome is not optimal, then that person has the strength and the power to keep going. Because one of the biggest challenges of IVF and one of the biggest regrets that we all have for our failures is when people give up, because then they will have zero chance. You know, we're talking about what's the risk of recurrent miscarriage is small risk. Even a miscarriage is indicating of a success in the future, blah, blah. We all know that on one condition, that person will not give up. And unfortunately, many give up. And I think that holistic approach, but real holistic approach with evidence, and acupuncture is supported by evidence, may give us that. And equally, lifestyle. Lifestyle is nutrition. Lifestyle is avoidance of alcohol, of smoking, of illegal drugs. I mean, today I had a wonderful patient, fertility patient. Most of my fertility patients are in their 40s. So as soon as they have their children, I still see them as my well woman clinic patients, which is, again, it's an extension, in my opinion, of our duty, because our duty is not finished when someone gets pregnant, not even when someone delivers a child at 45, 48, 50, 54. We had a pregnancy this week at Embryoclinic. In Greece, it's legal to perform IVF under conditions, of course, and following very, very thorough assessment and following specific license from the authorities up to 54 years old. But our duty is to keep them fit and healthy. So that amazing person, when she was filling in our well woman questionnaire, and she said, "Oh, I only drink 5 or 6 units of alcohol per week." And I said, "Okay, fine. Okay, well, how do you calculate this?" That was this morning. I said, "Well, it's 5, 6 glasses of wine." No, 5, 6 glasses of wine is 12 to 16 units, depending on how big is the glass of your wine. So simple thing. And we're talking about a highly educated person with PhDs, who's successful, 2 children, blah, blah. So of course it's important, but it's our fault because we don't talk to you about this. We don't have the time, we don't have the energy, perhaps, we don't have the people. And thank you for bringing this up because it is very important.
Definitely. Thank you so much indeed, Dr. Tsakos. There are like 2 questions left, but I think it's up to you if we can answer them. If not, we will be finishing. However, I'll be happy to forward this, and of course, I'm sure you will be able to.
Don't mind, yeah, please forward
I
them.
know it's really late for you, so we will see.
Yeah, it's getting a little bit late.
Thank you so much, everyone, for joining.
So much. I invite everyone from this webinar, drop me a line to info@embryoclinic.eu. Send me your questions, no problem at all. My wonderful coordinators pick it up. We have a wonderful lunch break every day, all of us, and I'm more than happy to answer your questions via email. If you need a second opinion via an online consultation, feel free. Anything I can do to share my experience with you. Most of you are very experienced with your doctors, perhaps contributing part of your journeys. I mean, tomorrow I'm doing surgery on a wonderful patient who's going to have an embryo transfer in Serbia and is coming in here to have some laparoscopic and hysteroscopic surgery. So feel free, share your thoughts. I'm very, very happy and grateful to the European Fertility Society, Caroline personally, the people behind her, her bosses, her partners there, my sponsors. This is a privilege for me to be able to share a little bit of my knowledge, but also my insecurities and my don't knows with you. Thank you so much.
Thank you so much indeed. It's always great to have you. So thanks a lot for joining us once again. Of course, there are plenty of more events. And actually, Dr. Tsakos will be back this week on Thursday. So you can definitely join us on Thursday. Dr. Tsakos will be joined with Dr. Walker from Instituto Marquez. So it's going to be a great discussion. You can go to myfvfensus.com and already register for it. Thank you everyone for your questions. As I mentioned, we will forward all the questions that we were not able to answer, but of course, stay tuned. There are more events coming up. So thanks a lot for your time. And Dr. Tsakos, see you soon. Take care, everyone.
Take
Good
care.
night.
Bye-bye. Thank you, everyone. Bye-bye. Bye.